mother would have believed her. So good morning, everyone, and let me join with the other organizers of this summit in welcoming all of you to this event. It comes at a critical time, a point of transition in our nation's history, and at a time when people of goodwill working together can get this job done, can get rid of lead poisoning as a public health problem within 5 years. As Secretary Castro said, it's not a question of knowledge, it's a question of resources, and it's a question of will and leadership. So let me begin by briefly reviewing with you. I know some of this has been said already, but it's important to lay it out systematically. Let me briefly review with you what we know about lead, what we know about the toxicity of lead. So lead's an ancient metal. Humans have been working with lead for 5,000 years. But it's only in the past 150 years that it's become widespread in the human environment, because starting about 150 years ago, lead mining accelerated, new instrumentation became available that enabled large-scale lead mining. That resulted in the lead industry developing products for the lead. They developed lead paint, they developed lead pipes, they marketed those products aggressively, and today, as we well know, they're ubiquitous in American society. Lead's a very toxic metal. It used to be thought in ancient times as an occupational poison because the only people that got poisoned were miners, people that worked in smelters. But after consumer products such as lead paint, lead pipes became widespread in society, children were exposed for the first time. The first recorded cases of childhood lead poisoning were in the first decade of the 20th century, 1904, down in Australia. We know that at high doses, acute exposure, lead causes coma, it causes convulsions, it causes death. Almost 40 years ago, when I was a pediatric resident, we still, from time to time, would see those children with that kind of acute lead poisoning. Dreadful. And the ones who recovered were left, obviously, permanently damaged. But what we've learned since that time is that lead is much more than an acute poison that causes devastating illness in a small number of children. In fact, it's a silent poison that pervades our society and causes silent injury to millions upon millions of American children. So what does it do? We've heard many of the elements over the last couple of days. It reduces children's intelligence. It reduces their IQ. It shortens their attention span, and that increases their risk for attention deficit disorder. It diminishes their ability to make reasoned judgments, to anticipate consequences. In other words, it makes them more prone to impulsive behavior. It reduces their achievement in life. Kids who've been exposed to lead have higher rates of school dropout. They're more likely to get arrested. They're more likely to get into drugs. They're more likely to commit violent, serious crimes. Lead has societal impacts. Lead doesn't just poison individual children, it does that, but it also dumbs down the whole society. It impairs all Americans when a large fraction of our children are rendered less intelligent because they've been exposed to lead. And that has national economic implications. If the whole country is a little less intelligent than they might have been, if a whole generation of children is operating with less than their full intelligence, which is certainly the situation that we were in this country in the 1960s and 1970s, when we were systematically exposing the whole American population to lead from gasoline, then the whole society operates at a lower level, is less economically productive, is less creative than it would have been. And I would argue, as somebody who served for a long time in the Navy and the Public Health Service, that when the whole population is impaired by a neurological toxin such as lead, that situation has real implications for national security. It is not good for America. It is making America anything but great if we systematically poison a whole generation of children. So where do we stand with lead today in this country? We've made some real progress. In fact, we've made some enormous progress. Over the past 30, 35 years, we have reduced children's blood lead levels in this country by over 90%, which is an amazing accomplishment. We did it by getting lead out of gasoline, by getting lead out of new paint, by getting lead out of tin cans, it used to be on the seams of tin cans, and by getting lead out of plumbing fixtures and pipes installed since the 1980s. How do we do that? We did it through partnership, we did it through coalition. I was involved, some other people like Herb Needleman, Katie Mahaffey, Ellen Silbergill, Julian Chisholm were involved in endless meetings in the 1970s at the EPA when it was debated whether lead was toxic to children at levels below the levels that cause coma and convulsions. We actually used to have those debates with the lead industry sitting on the one side of the room saying, no problem, and us sitting on the other side of the room. And the reason that we were able to beat back the lead industry, the reason that we're able to get lead out of gasoline and out of paint was because the doctors got together with the nurses, who got together with the health educators, who got together with the parents, who got together with the community groups, who got together with the faith groups, who got together with the NAACP and created this, and with the unions, and created this enormous coalition. That was the first element of our success, and that was very important. We need to reconstruct that coalition here, which in fact we're doing because we're all sitting here together. The second thing that enabled us to succeed in that was that we were able to split the opposition. When we started out in the battle against lead and gasoline, we were dealing with a trifecta: the lead industry, the auto industry, and the petroleum industry, and they were all joined in the fact that they liked to put tetraethyl lead into gasoline to make cars go faster. Something changed, though, midway through the debate, and that was that in the early 1970s, it suddenly became the law of the land that new cars in this country needed a catalytic converter to prevent air pollution under the Clean Air Act. Well, those catalytic converters contained platinum. Lead in the gasoline killed the platinum. All of a sudden, the auto industry didn't want leaded gas anymore. And soon thereafter, the petrol industry didn't want leaded gas anymore because they needed the auto industry. That left the lead industry out there by themselves. We were able to drive through that gap, and we could win. So we have to look for strategic opportunities here. We need partnership, but we also need to be smart and strategic, and we need to look to see how it works. And it's also very important to talk about the centrality of persistence in these kind of battles. You don't win these things overnight. These things take months, they take years, they take patience, they take resilience, they take people who can stand the occasional defeat, like a national election, and can still just keep building, quietly building the coalitions and charging on. And that's what we have to do. So what's the status of lead in America today? The good news, as I said already, is that through enormous efforts of the last 30 years, we've gotten rid of enormous amounts of lead in American society and knocked lead levels down by more than 90%. But there's still a huge lead problem. We learned that in Flint, we learned it in Newark, we learned it in Cleveland, Ohio, and other places where lead has been discovered or rediscovered in recent months. CDC says that there are 535,000 children today with blood lead levels greater than 5 micrograms per deciliter. That's a 500,000 children. You know how many people died of Ebola in this country? And we got all excited about it. Anybody know? I looked it up last night, so I've got good information.
It might have been fake news. It might have been fake news.
It was 8. It wasn't fake news, it was real news. It came from CDC, you can believe it. It was 8 cases of Ebola. How many cases of Zika have we had to date? I know the number is rising, but how many so far? 32,000. So 32,000 Zika, it's not a small number, but 535,000 show more lead. And yet, I don't want to take anything away from Zika, and I certainly don't want to take anything away from Ebola, but why has lead been ignored for so long? So just think about that, reflect on that. Also, housing. Nobody knows precisely how many houses in this country have lead, but the number is somewhere around 40 million, with roughly half of them having what is termed a hazard, meaning that the lead paint is deteriorating and cracked and chipping and poses a risk to children. We have somewhere in the neighborhood of 10 or 20 million houses with lead service lines coming in from the street. So there's an awful lot of lead. There's an awful lot of lead out there, and we need to address it. For too long, the way we've dealt with lead in this country is that we've used children as the canaries. We use children as the biological monitors to tell us where there is lead. We screen kids, not very well, not very thoroughly, but we screen populations of children, and we say, that neighborhood, Bushwick in Brooklyn, this neighborhood in Flint, that neighborhood in Oakland, California, has lead because why? Because the children's lead is bad, so there must be a problem. That's not the way we go after other public health programs. We went after smallpox by identifying the vector, developing a vaccine, and going in. We're developing a vaccine against Ebola. We're developing a vaccine against Zika. We're going after root causes on all of those diseases. We haven't traditionally gone after root causes on lead in this country, and we need to change that strategy. So colleagues and I have called for a strategy that begins by systematically mapping all of the lead in this country, block by block, house by house, identify all the places where there's lead paint. Individual cities often have this information in state health departments, but we don't have a national map. This is an era when NASA can map the location of water on the non-planet Pluto, and we don't know where all the lead is in American cities. It's scandalous. Same for lead pipes. And then once we have that information, or even as we're getting that information, what we need to do is we need to build a jobs program, a green jobs program in this country, in partnership with the big unions, the plumbers, the carpenters, the laborers, the other construction trades, and take young people, even unemployed young people, put them to work in apprentice programs such as Karen Walker, the mayor of Flint, described last evening, where they're not just doing a once-off job with a bandana around their face, but rather doing a proper union job with an apprenticeship program and training and safety school, and put these young men and women to work, abating lead in this country. And that will clean up neighborhoods, it'll put kids to work, it'll save a generation of children, and it will give the young men and women who participate in these programs a lifetime of solid union employment. And those jobs aren't going away. Construction trades don't move overseas, they'll be here. Think about the economics of it. You know, it's very easy for people to talk about the high costs of lead abatement. And lead abatement will be expensive, no question about it. It's going to be billions of dollars, lots and lots and lots of money. But it's relatively easy to compute the costs of abatement because it's here and now. You can measure labor costs, materials costs, come up with a figure. It's much more difficult to measure the costs of lead poisoning itself because it's spread across millions of children over years and decades. But we now know it's trillions of dollars. Dr. Elise Gould, from whom you're going to be hearing from a little bit later this morning, has computed that every dollar spent to control lead poisoning produces a yield of at least $17 and maybe as much as $221 for every dollar invested. Even Bernie Madoff couldn't get you a return like that. That's an extraordinary investment. And Joel Schwartz at Harvard and his team, Tom Mattei, Dick Jackson, computed the cost savings that accrued to this country from the removal of lead from gasoline. And they computed that in every birth cohort of American children, every annual crop of children born since 1980, the economic benefit to this country is $200 billion. Now, how do they get that astounding number? It's easy. We have 4 million babies per year. Give them each 5 IQ points because they're no longer having to contend with lead and gasoline. So that's 20 million new IQ points per year in this country since 1980. The economists tell us that an IQ point's worth roughly $10,000 over a child's lifetime in terms of increased earnings, increased productivity. So 20 million IQ points times $10,000 per IQ point, that's $200 billion in every single annual crop of babies born in this country since 1980. That's an aggregate benefit since 1980 of about $5 trillion. Do the math. It's extraordinary. I think it would pay for lead removal. And finally, bear this in mind, lead removal is a one-time cost. Spend a lot of money, get rid of that paint, dig up the pipes, replace them, and it's over. lead poisoning that is left untouched continues year after year, generation after generation, which we've seen already in this country. It's time to end it. So I've said enough. I want to turn this over to my partners in crime, Jennifer Lowry, and the hero of Flint, Dr. Hanna, Attisha. Go ahead.
Down here?
As you wish.
Okay. Well, you know, this was kind of how it was last night, where we all just sat around and had a conversation. So I'm happy to do that. So I've been told that we need to catch up on time, so I'm going to give you that piece of paper. So I am Jennifer Lowry, as it says. I am from Kansas City, that you heard yesterday. And I also serve as the chair of the Council on Environmental Health for the American Academy of Pediatrics. The American Academy of Pediatrics, we have over 66,000 pediatricians who are members, and we serve children. Our whole job, as Dr. Hanna Attisha will tell you, is to make sure that children are well cared for and that they are safe. In regard to the Council on Environmental Health, we've taken that a little bit further, and then also safe from environmental exposures. And in this case, we're talking about lead. In June of 2016, we did release our lead policy statement. I don't know that you have all seen that. It was actually Bruce Lamphey, who is here somewhere. Bruce, where are you? I don't know. Anyway, he's back there somewhere, not making eye contact with me back there. He's way back there. He was actually the lead author on this, and but as a council, we went through and systematically looked at it to see how best we could serve the children and advise it. So if you look at the comparative of the 2016 versus the 2012, there are some substantive changes in that our advocacy really needs to be primary prevention. We cannot, again, have our kids poisoned, and then we find them using capillary blood tests to then find that they're poisoned and they've already been harmed. Our job is to prevent them from the first place. We need to, before children are sent home from the hospital as a baby, need to know where they're going. We need to know what their home is like. We need to, at every anticipatory guidance, talk about the effects of environmental exposures and lead and make sure that we inform our families about that. As you also mentioned from me, as you also heard yesterday, unfortunately, not everybody is on the same page, in that our children get poisoned first, and then we have to react. We have landlords who don't want to or can't fix the homes, but we also have families who are unable to do that themselves. I also serve as the director to the Pediatric Environmental Health Specialty Unit for EPA Regions, or for Federal Region 7. It is a program that is run by the American Academy of Pediatrics and the American College of Medical Toxicology, and funded by the Office of Children's Health Protection at the EPA and the Agency for Toxic Substances and Disease Registry. Each region has their own PACU, and so I serve Region 7, which is Iowa, Nebraska, Missouri, and Kansas. And when the CDC took money away from the states to fund their lead poisoning prevention programs in 2012, the state of Kansas actually got rid of their whole program. There is no lead poisoning prevention program in the state of Kansas. There are no home investigations in the state of Kansas. There is very little case management in the state of Kansas. And I don't know that Kansas is any, I mean, obviously there are states that do a better job, but I have over 400 children of every socioeconomic status that are poisoned by lead. I also have, and they're not all lead paint. They're from oil fields where the lubricant that they use on the pipes are made of lead, and as you know, lead is sweet, so the parents come home with the oil on them, the kids lick it, and they get poisoned. I have kids whose parents make bullets in the basement of their homes, and in doing so make the lead available to them by inhalation and get poisoned. I have kids that are older than 6 who have sensory issues, and so their dads give them the fishing weights because they're heavy and they can actually move them around in their hand to help them. Of course, those fishing weights are made of lead, and so as they move them around, the lead dust gets on their hands and then they get lead poisoned. I have kids whose parents work in firing ranges or battery plants who then come home with the lead dust on them because they're not employees, but they're contractors in the industry, and so the rules don't actually apply to the contractors, and so they come home with lead dust on them, and kids get poisoned. We can talk about poverty, and the American Academy of Pediatrics has had a large focus on poverty, but it goes across all children. I take care of kids in St. Louis and in St. Joseph, Missouri, and St. Louis has a phenomenal Healthy Homes program where they can react very well, in Kansas City, very well to children that are lead poisoned. But St. Joseph, who has less poverty, because we have more families that are just above the poverty line, who are not African American, they're blue-collar families living check to check, own their home, but they have lead and they have no resources. And they feel like they've been left behind. So while we have this conversation, know that all children need to be cared for in this time of when we're talking about lead. And with that, I'm going to turn it over to Dr. Mona and Attisha.
It's great to be here. My job is, I'm a pediatrician in Flint, Michigan, and my job as a pediatrician, all of us here are pediatricians, is prevention. Everything we do is to prevent problems and to optimize children's health. We give immunizations, we talk about anticipatory guidance and safety, and wear your seatbelt and your helmet, and eat right, and wear a condom, and do all these things to prevent problems. And one of my experience in Flint is, and taking it a step further, is really trying to prevent future Flints. So I am so happy to be here because we have so many lessons that we have learned. Flint never should have happened for so many reasons. But if we can take what we learned in Flint and raise it to this national conversation so that you can go back wherever you are and strengthen policies, both at the local, state, and national levels, to prevent what we are still in the middle of a crisis. By now, hopefully you have all heard of the Flint story. We are in our 3rd year where our children cannot drink the water that comes out of our tap. And I know there's some Michigan people. There's Wes. Any other Michigan people here? Awesome. Yay, awesome. So people from Michigan, we use a hand, right? This is how we represent our state. We're the mitten state. And you kind of say where you're from. You're from Flint, you're from Detroit, you're from Grand Rapids. And we use a hand because we're surrounded by the Great Lakes. So Michigan is literally surrounded by the largest source of fresh water in the world. And we have a city right now still, Flint, Michigan, a clearly demarcated city that is predominantly poor, that is predominantly minority, that has yet to have access to safe drinking water. So Flint has an incredible history, was the birthplace of General Motors, the birthplace really of the unions, the birthplace of the middle class in America. At one point, Flint had the highest per capita income in the world, in the nation, and was really an industrial center, but has suffered significantly from disinvestment, from unemployment, from racism, from poverty, from violence. Before this, I was treating kids with lead poisoning because of retained bullets, and every other reason for lead poisoning. And then Flint was almost bankrupt, and in 2011, we lost control of government, so we were under state-appointed emergency management, and that emergency manager's job was austerity. It was to save money, and it was decided that the water that we had been getting for half a century, pre-treated, fresh Great Lakes water that came from Detroit, was too expensive, and that we would start drawing water from the local Flint River, which would have been fine, but the Flint River water was not being treated properly. And this is when I started, becoming a water expert. So you never expect that from a pediatrician to know something so much about water. Anyways, so the water was missing an important ingredient. It was missing a medicine, you can say, called corrosion control. And evidently that is a necessary part of all water treatment. And this corrosion control was not added to the water, and that created a perfect storm for the lead that is in our plumbing, that is in all of our plumbing, because we were stubbornly slow as a nation to restrict lead from our plumbing. We didn't restrict it from service lines till 1986. We didn't restrict it more from our fixtures, our brass faucets, till 2014. So this lead that was in all of our plumbing got eaten up by this corrosive, untreated water. And then the lead went into the drinking water and into the bodies of our children. And for 18 months, the people of Flint were told to relax, that everything was okay while they were drinking contaminated water. And from the moment that really we proved that lead was increasingly in the bodies of our children, where we failed at primary prevention in the world of public health, in the world of lead, you are never supposed to expose a population to lead. So we failed at population. So then our focus very much shifted to secondary prevention. We now have this population that's potentially exposed. They're not all going to have problems, and that is our goal, and definitely my goal as a pediatrician, to make sure that they don't have problems. So we are kind of ground zero on lead contamination, and we're trying to do something that hasn't been done before. We're trying to build a model public health program to wrap our kids with everything we know that will help them, with evidence-based interventions like maternal family support, early literacy, home visiting, universal preschool, school health services, nutrition access. Jackie mentioned nutrition in Flint. We have no full-service grocery stores. We have low breastfeeding rates, 2 reasons that we were even harder hit by this problem. Healthcare access. So we are trying to do all these incredible things for our kids because they are definitely owed this. We continue advocacy. Congress has yet to pass $0 for Flint, and we have yet to have safe drinking water, and we have yet to really garner the long-term resources for the recovery of our children. These kids did nothing wrong besides live in a city that was poor, that didn't treat its water properly, and we owe it to them to really turn the story around. And that's very much how I spend my everyday, but I am so excited that we are now talking about lead. As a pediatrician in public health, we thought we took care of lead. Lead was a problem of yesterday. As physicians, we even stopped screening for lead. We're like, oh, it's okay, nobody has lead anymore. Look at that great curve, it's gone down. We don't have to worry about lead. But it's a problem of yesterday, it's a problem of today, and it is a problem of tomorrow. So we need everybody to refocus on elimination so that we do not have another Flint. Any child, anywhere, in any city should not be exposed to lead, and we can do something about it. Thank you.
I just want to comment on something that Mona said. I think that there's a misconception maybe a little bit about what happens in the pediatrician's office when it comes to lead. And Mona can correct me because she's in more of the pediatrician office than I am, but as a general pediatrician. So we have a number of different words that we use. We're going to screen for lead. We have, again, lead capillary test screening, and then we have the venous sample. So CMS requires that all children that receive Medicaid at 1 and 2 years of age be screened for lead. That's the capillary blood test at least, if not the venous. They would need a blood test. When we do targeted screening, though, that doesn't necessarily, that also means the blood test. But I think a lot of the education that I have to do, and with Mona's help and all the other pediatricians here, is explain to pediatricians that the lead questionnaire that the CDC has in many states, which we also call screening, is actually not the screening that we're talking about. All children need the questionnaire done. And unfortunately, the questionnaire doesn't get all of those exposures that I just told you about. We don't ask, is your father making lead bullets in your basement? I mean, that's just not a question. But so we have to ask. We have to do that test, or ask those questions when we can. Hopefully, in my case, I would hope it would be at every anticipatory guidance, because things change. But we don't ask those questions. And because we don't ask those questions, we don't get the answers, and then sometimes that doesn't lead us to the capillary test. The other thing that happens quite often is we get the capillary blood test, which is a finger stick, and parents, freak out because, you know, they want their child having a finger stick. And so they get the finger stick, and it may be that the lead level is 25 or 45 or whatever the number is, right? So, and of course we freak out because we don't want that lead level that high. So our requirement is to get the venous confirmation. So we get the venous confirmation, and yay, it's not 25, it's 6, which clearly for all of us, we know that that's still bad, but it's not 25, or maybe it's even like 3. And so what happens in the physician's office is, oh, your lead is normal. Okay, so I do a lot of education on, no, there's no normal lead level. You know, you're not supposed to have lead in you, so there's not a normal number. That said, then they're like, oh, phew, it's not 25, and it's really not there, so we don't have to do anything. And part of our thinking needs to change. Of course it's there. The capillary was 25. Where did that 25 come from? Well, the 25 came from because we didn't wash off the hand very well, and so it got the lead dust on the skin for us to know that there was lead there, but the venous has been confirmed as negative. That doesn't mean that we stop there and we don't help that child, because actually what that is, that actually turns into primary prevention. Because we can prevent that child from being exposed because we know that lead dust is in that environment because it tested positive on that capillary. And so our focus needs to change again from reacting to that 25 or that 45 to that capillary was high, we need to do something to prevent it from actually getting high at a venous. So that's the conversation I think that we need to have.
Thank you. So we've got about 20 minutes left, 18 minutes left before the next session. We're open for Q&A. We'll take the first couple of questions off the Twitter screen, which we can see down in front of us, and I guess you can see.
It's a Twitter screen now.
Huh? Yeah.
3 o'clock in the morning. No, I'm just kidding.
So let's see. I have to read these for a minute. The first one says, what are the biggest barriers to changing public will for this issue? I think there are a number of barriers. I think some of it is inertia. Lead's been around for a long time. As Mona said a moment ago, a lot of pediatricians, a lot of Americans think that lead is yesterday's poison, or at least they thought that until Flint. They thought that lead was yesterday's poison, we don't need to worry about it. Then there's racism. There's the sense, oh, it's their children, we don't need to worry about them. First of all, that's immoral, but beyond that, it's scientifically inaccurate. About 20% of our lead-poisoned kids in New York State, where I am, are middle class and above. Their lead comes from things like home renovation, imported French dinnerware with fancy lead glaze on it. Nobody's child is immune to lead. Lead affects everybody's child. It affects a higher proportion of kids in some populations, no question about that. The epidemiology is clear, but it affects everybody's children. So I think inertia, racism, the ability that we humans have all too easily to shut out problems that are not affecting us and our loved ones here and now. And then finally, and this is what we're trying to fix with this meeting, is lack of leadership, lack of political will. This is a soluble problem. This is not an inevitable part of living in the 21st century. It was human activity, the creation of lead paint, the creation of lead pipes, the creation of the lead products, bullets, everything else that caused the lead poisoning problem in our country. And if political leadership stands up and says, part of making America great again is to give us a generation of children who are untouched by lead. Part of making America's infrastructure great again is rebuilding cities and getting the lead out of cities as we rebuild them. Then we will have done the job. We can come back here in 5 years, and as several people have said before me, we can have a celebration. There's probably other factors I didn't think of. I was exposed to lead as a child, so I can't remember everything. But those are the obvious ones. All right, shall we take a question from the floor? If somebody has a microphone, I don't know where the microphone is. I can't see it from here.
It's back there.
Way in the far back.
Hey Phil, Rebecca Morley. I actually had a question for Mona. I saw reported recently that the number of lead service lines in Flint was originally estimated to be 8,000, and they're now estimating 29,000. I'm just wondering if you could say anything about the upward estimate, and what does that mean for our national estimates of how many lead service lines there are around this country?
Yeah, so that's a great question. So in Flint, our service lines, we're in the Public Works office and 44,000 index cards. And that is not atypical. In many communities, they don't know what is underground, and that's often purposeful because they don't want to know where their lead lines are. So now the estimates are going up, and obviously the cost will go up. But part of that mapping that needs to be done is also the mapping that needs to be done underground to know where these lead pipes are. And it is not just a service line issue, it's also what's inside the premise property, what is inside people's homes, because there's a lot of solder, there's a lot of faucets, there's a lot of fixtures that had lead lines. And one example is in our Flint community schools. Our Flint schools, big buildings didn't have lead lines, they didn't have big service lines, but our Flint schools had some of the highest water lead levels. And when they did the testing, it was the fixtures that had high lead. It was the faucets and the fixtures that had high lead levels. And those had to be replaced, and they had to be replaced with fixtures that were built after 2014, because that's when we cut lead from the fixtures.
Other questions?
Yes, it seems to me there's a direct parallel to asbestos, and in the asbestos arena, there were many practical applications in housing that led to serious problems, and there was class action lawsuits that forced all the companies who had been involved with asbestos to remediate and deal with health claims. I'm wondering why that's not the case with respect to lead.
Well, I think there probably are some lawsuits brewing now, is what I've heard that rumor. I can also tell you a story. About 15 years or so ago now, Sheldon Whitehouse, now United States Senator, but at that time Attorney General for the state of Rhode Island, brought suit on behalf of the state against the 5 major manufacturers of lead-based paint on the grounds that for 4 or 5 decades, those companies had knowingly sold a hazardous product, lead paint, in the state of Rhode Island. The first trial, and full disclosure, I was an expert witness for the state, along with Bruce Lanphier and some others in this room. First trial ended in a hung jury. They brought it again, and the state won. And the lead companies were on the hook for millions upon millions of dollars, which would have gone into the state remediation fund. The money was earmarked for that. But it was appealed, it went to the higher court in the state of Rhode Island, which did what's called a directed verdict, and threw it out. End of story. But I think it's a legitimate avenue. I've done a lot of asbestos work over the year. We don't yet have a ban on asbestos in this country, thanks to the failure of the old Toxic Substances Control Act. But legal suits have made an enormous difference in controlling the use of asbestos in this country. We're not rid of it, but we're way, way down from where we used to be. And the numbers of deaths from lung cancer and mesothelioma reflect that.
So we were asked to take some of these questions from here. So the first one on top is, how can we encourage more hospitals and health systems to act as anchor institutions in communities to address exposure to lead? I think as Mona and I have probably talked about here, is that you need a champion. You need someone to take that on. We have many healthcare professionals and including some pediatricians who would say that it's not necessary to test children for lead because they haven't seen it, because of where they are in their practice. And so it's really getting the advocates to address this. My hospital institution has allowed me to champion the lead poisoning movement, I guess, or the lack prevention program that we have, and to be able to do case management. And so it's really finding that key person in the communities, working with the state chapters of the American Academy of Pediatrics. I mean, again, we're an organization of 66,000 pediatricians across the country who can work with their state chapter, who can then work with the Council we can help to educate that. Also, I want to put another plug in for the pediatric environmental health specialty units. Each one of you has a pediatrician who works for you in your region. So you need to find that person. Go, it's pehsu.net, PEHSU.net. And you go on there and you find your pediatrician and say, how can you help me get our testing up? How can you help me take care of this? How can you help me be an advocate in my community? That's my job in Region 7. I do that, and you have that across the country, and so you need to use the advocates that are available to you to get this done.
So nonprofit hospitals also have to do something called a community benefit, so they have to give back, and we can encourage them to have that effort go back into lead prevention and lead education awareness. Sure, there's a question about Flint. From talking to people in Flint, we understand that many of the water heaters in homes have been corroded by the water. Is there a plan to address this? All appliances that touch the water are issues in Flint. They've been damaged, and many people have have filed lawsuits and insurance claims and different things. There is no comprehensive plan that I know to address this. There are some nonprofit funds that are available, but yeah, it is not just it's everything that touched water that was corroded.
Another question from the room?
I'm Gail Gattins. I'm a child development specialist. I'm with New Hampshire's Healthy Homes and Lead Poisoning Prevention Program. First, thank you to all three of you. I have a couple of different questions. The first one was one of the biggest issues we're dealing with in even getting blood level tests reported is there's no way to have it come in electronically directly from children's electronic health records, similar to immunizations or other infectious disease reporting. And literally in our office, a great number of them come in on paper by fax that we then have to re-enter into our CDC databases. So as we work to get more children tested, that's an issue that I hope many in the room can put collective effort on, because if we get antiquated at best.
Let me answer that, or let me respond to that before you go on to your next one. In New York State, a number of years ago, the first governor, Cuomo, got legislation through which requires that every blood lead determination and some other determinations as well that are done by laboratories have to be electronically reported to the state health department by the laboratory that does the work. And it doesn't matter whether the laboratory is based in our state or based in Kansas. If they're going to do business in the state, they have to report or they're breaking the law. And that's I don't know if it's a complete fix in New Hampshire, but it will help.
A lot of our larger laboratories, like ARUP and MedCore, do come in electronically. There's still a certain amount of cleaning and cutting and pasting that you have to do from those huge reports to get them into the other databases that get reported in quarterly. But all of the point of care done with the LeadCare 2 devices, which have been proven research, the research shows that if you want to increase your testing rates, go to point of care. And those appliances usually are done in the office, goes into the child's EHR, the electronic health records, and there's no way of reporting that in directly electronically. At least in New Hampshire, we get 1,000 faxes a year. So there's.
But you're getting faxes. Some people don't even send those on.
Okay. So we have to report it. It's just a piece that if we want to improve our testing rates, and I'd also like if we could clean up the jargon. There's screening, which means asking a series of questions to determine risk factors. That's screening. Testing is when you do a blood test. So if we're using point of care devices, which greatly improve testing rates, when those are done in the office, there is no way of getting it reported in electronically off the child's electronic health record.
Okay, just want to clarify that. CMS says screening is the blood test. The questionnaire is not a screen, it's the questionnaire. This comes right from CMS to my ears. So that's actually part of the problem, is that people don't understand. we have so many different languages
Right.
going on that CMS actually interprets that differently.
So we have a questionnaire by your interpretation. New Hampshire screening guidelines, we have a screening questions, and then we have a test.
Right.
The other piece that I wanted to bring up is that we're all here talking about the fact that we need more children tested. We want more children to have their blood tested to determine whether they have an elevated blood lead. So in New Hampshire, we're working very hard to move away from a universal and targeted approach for our communities to making our state universal. We hope there's new legislation going in January to hope to bring this through. But the American Academy of Pediatrics, in their July article, just past July of 2016, recommended moving away from universal testing, moving to a targeted approach. And I just thought that was really unfortunate.
So actually, it does not exactly say that. It says that in the 2012 document, we actually agreed with the targeted approach. If you actually finish the paragraph in reading that, there's the last statement in there that says this needs to be revisited because it's not where we need to be. So I have a copy. I'm happy to share it with people, but it does need to be revisited because there are more nuances than just the targeted approach.
Prior to that, the recommendation had always been universal testing at 1 and again at age 2 tests, unless there was a separate state guideline. So that policy was retired, and then the article came out in July of 2016 that recommended moving to a targeted approach. So you're saying
We can talk.
more about that.
That's not accurate.
I think our time is
Yeah,
up.
our time is
So
up.
I want to thank my fellow panelists, thank all of you for the discussion. We'll close and the next session follows directly, correct? Yes, the next session follows directly.